Welcome to this video on mediastinal drain removal. Mediastinal drains are inserted during cardiac surgery to prevent blood or fluid from accumulating in the pericardial space, to prevent subsequent tamponade, and to allow monitoring of blood or fluid loss post-operatively. Drains are connected to an underwater seal, and the position of the drains should be checked during the surgery. Although surgeons will have different preferences, common drain positions include a straight drain in the anterior mediastinum overlying the heart, or a curved drain inferior to the heart within the pericardium. Further drains may be placed into the pleural spaces if these are opened at the time of surgery. Exit points are through the muscle wall via transverse incisions below the xiphisternum. Be extra careful as the pericardial space is above the diaphragm, hence diaphragmatic tears during drain removal can cause hernias. In this way, both drain insertion and drain removal can cause diaphragmatic injury. The risks of drain removal are localized bleeding, hemothorax, cardiac tamponade, pneumothorax or pneumomediastinum, and pain. The benefits, however, include freeing up patients to mobilize, it removes a potential source of infection, prevents atelectasis by allowing deeper ventilation, and reduces chest pain, also aiding deeper ventilation. Drains are usually removed in the first couple of days post-surgery when there is minimal drainage of serous fluid in 24 hours or 3 consecutive hours, according to surgeon preference. Ensure it is performed using an aseptic technique, that there is adequate analgesia given to the patient prior to starting. Ensure the INR is less than 2, and if the patient has pacing wires, ensure they are rolled to avoid tangling. You will also require an assistant for this procedure. Prepare your equipment adhering to infection control policy. You'll also require a suture removal kit and sterile dressing materials. It is useful to keep an extra suture in case the purse string is ineffective or if there's a larger incision. Position the patient supine at a maximum of 45 degrees and clamp and disconnect the drains. Explain the procedure to the patient, warning them of any pain or discomfort. Practice the breathing technique with the patient. Deep breath in, breathe out, deep breath in, and hold your breath. Explain that you'll pull the drain out at this point and then they can exhale. Clean the area and cut the anchoring stitch with a blade. Place gauze at the drain site with slight pressure whilst your assistant takes hold of the purse string suture. Ask the patient to breathe in, breathe out, breathe in and hold. Then pull out the drain with your dominant hand whilst the assistant tightens the purse string suture. Compress the drain site with gauze as the patient exhales while the assistant ties the purse string suture to close the wound. Place a sterile dressing over the wound and tell the patient to inform staff if they are short of breath or develop chest pain. Optimize analgesia and encourage mobilization. The patient should be on a cardiac monitor for 24 hours. Unlike pleural drains, a post-removal chest X-ray is not usually required, and drain stitches can be removed after 10 to 14 days. Here is a summary slide of the steps of the procedure. Excess bleeding is avoided by ensuring coagulation levels are within range and with firm compression to achieve hemostasis. Air leaks, surgical emphysema, or pneumothorax can be avoided by ensuring drains are removed on full inspiration with the breath held. You can avoid injury to surrounding structures by being gentle yet swift. Stop the procedure and inform doctors if you feel resistance whilst withdrawing the drain, if the patient desaturates or has a high respiratory rate, if they become hemodynamically unstable, or if you see arrhythmias on the cardiac monitor. This concludes our video and thank you for watching.